Hello, everyone. Welcome to day 2 of the CCIH annual conference. My name is Mona Bormet, and I am the program director at Christian Connections for International Health. And it's my pleasure to start the day with you and to share a few logistics about the conference with you as we start. So you should see a slide with instructions in French and Spanish about how to join our language interpretation channels. So at the very bottom of your screen, there should be a button that says interpretation, and you can choose English, French, or Spanish, and we encourage you to choose that language now. We are very glad you're here. And as Deirdre has been putting in the chat box, we encourage you to please introduce yourself, tell us who you are and where you're joining from. It's fun to see everyone who's joining. And as I said, we are glad you're here. Welcome to the CCIH 2022 annual conference. If you are new to CCIH, welcome. I know there's new and old friends here. CCIH is a global network of approximately 120 Christian organizations and 15 secular partners, as well as a few hundred individual members. Our mission is to promote health and wholeness from a Christian perspective, and we provide opportunities for capacity building, networking, sharing best practices, and advocacy. So that's CCIH in a nutshell. We are grateful for our sponsors who've helped make the conference possible. As you know, we've made this conference free for all of our low and middle income country participants and students and our CCIH members, but running even a virtual event is far from free. So very grateful for our sponsors represented on this slide here. And a special thank you to all of our sponsors today. We are also grateful for the support of United States Senator Roger Wicker, who has represented the state of Mississippi in the US Senate since December of 2007. Senator Wicker has actively supported cancer survivorship programs, efforts to fight heart disease, diabetes, childhood obesity, and Alzheimer's. He has been recognized as a champion of polio eradication for his work to wipe out polio worldwide. He is also the co-founder of the US Senate Malaria and Neglected Tropical Disease Caucus and has worked to eliminate these preventable diseases. So I'd like to start by turning it over to Senator Wicker. Thank you.
Hello, I'm U.S. Senator Roger Wicker from Mississippi, and it's my pleasure to welcome you to this year's conference, hosted by Christian Connections for International Health. Your participation in this event is an inspiring example of faith being put into action. You are on the front lines fighting disease, saving lives, and lifting human conditions. Your work is a powerful witness to the second greatest commandment, loving your neighbor as yourself. That work includes caring for some of the world's poorest individuals, those who are truly marginalized in what we call last mile communities. As a member of Congress, I have had a front row seat to some of your most vital work, such as the fight against malaria and AIDS in partnership with USAID. And I've been amazed at what we can accomplish together when government comes alongside faith-based health providers to support your life-saving work and to obey the words of the New Testament. In Matthew 25, Jesus said, "I was hungry and you gave me something to eat. I was thirsty and you gave me drink. I was a stranger and you took me in. I was naked and you clothed me. I was in prison and you came to visit me." When the righteous answer him, they say, "Lord, when did I do these things?" Jesus replies, "Verily I say unto you, inasmuch as you did it for the least of these, you have done it for me." Through CCIH's mission and programs, your collective efforts help us fulfill the commission of Jesus. Thank you for your work and for your example of faith working through love. God bless you all. Hello, I'm U.S. Senator.
Thank you, Senator Wicker. And thank you everyone for joining once again. Just a reminder that if you need interpretation, to press the interpretation button at the bottom of your screen and choose English, French, or Spanish. We will hold all questions until the end of the program today, and then we'll go into networking and breakout rooms, so approximately 9:45 Eastern Time. We will collect all questions until then, so please use the chat box to ask your questions. We have staff monitoring that. And the session is being recorded and will be available on our YouTube channel and also on our website, ccih.org, under events. And of course, we're excited to have you share what you're learning, something interesting, some helpful experiences from speakers. Please share on social media using the hashtag CCIH 2022, faith-based, or global health. And it's my pleasure today to turn it over to our moderator for today's session, Dr. Perry Jansen. Dr. Jansen is a family physician and served with SIM in Malawi for 16 years. He founded the nonprofit hospital Partners in Hope in Malawi, and now he is vice president in African Mission Healthcare. He leads initiatives to strengthen mission hospitals, to expand medical education, and strengthen local healthcare leadership. Perry is a CCIH member and is co-chair of our working group on leadership and governance. So excited to have Perry here, and I will turn it over to him. Thanks, Perry.
Thank you, Mona. I'm really excited to be facilitating this session today because I think one thing that we've all recognized is the important role that strong leadership and healthy governance plays in any effective ministry. But I think especially during times of crisis like we've been facing over the last couple of years with COVID and many other things, it really increases the importance of having these strong leaders and good systems in place. And so I'm appreciative of CCIH recognizing that and developing the leadership and governance subgroup, and also including that as a topic that we'll be really exploring today. Before we do that, let me just open us up in prayer. Lord, we thank you so much for this opportunity to gather. We so miss gathering in person and the fellowship that happens there. And yet we're grateful for the technology that allows us still to gather and learn from one another and have fellowship with one another. I thank you for CCIH's role in bringing together really disparate ministries from across the globe to come together as the body of Christ and share our experiences with one another and encourage one another. Please have your hand upon all the words spoken today and also on our technology, that everything comes together. And Lord, that in everything that we do today, that we would bring you glory. And we ask this in Jesus' name. As we're listening today to each of the sessions, I'd like you to keep in mind three different questions that we have that we'll be considering later. One is on ethics. The question is really, are Christians held to a higher standard of ethics because of our faith? Question two is on transformational leadership. How could we strengthen and inspire transformational leadership and good governance in our organizations? And third, on preventing burnout. How can we prevent burnout in leadership, particularly when the cause is good and the needs are so great? The pleasure in introducing our first keynote speaker today is author Kate Rademacher. Kate has 20 years of experience in public health and public health program design, management, and evaluation. She currently works as a senior technical advisor at FHI 360 and oversees a portfolio of activities under USAID funded projects. She's the author of several books, including Reclaiming Rest, The Promise of Sabbath, Solitude, Stillness in a Restless World, that was published in 2021. So Kate, we're so glad to have you and welcome, and we look forward to hearing from you.
Thank you so much, Perry, and thank you so much, and greetings, everyone. Thank you for having me. It's a delight to be here. Excuse me, I'm just going to clear my throat. Hold on. It's a delight to be here, particularly to talk about the topic of effective leadership while preventing burnout. This is a topic that is very near and dear to my heart and is something I explored in my most recent book, as Perry mentioned. So I look forward to diving into this today. Next slide, please. So some of you may know that burnout was recognized by the World Health Organization as an occupational phenomenon for the first time in 2019. This has gotten a lot of buzz in the news media, and of course, the problem has only gotten worse during the pandemic. There's been an increased attention to issues of burnout, and so we're going to talk a little bit more about that today. Next slide. There's actually quite a substantial amount of evidence documenting burnout, particularly with the focus among frontline healthcare workers. Most of the evidence focuses on burnout as a phenomenon among nurses, doctors, community health workers. And you can see here some of the examples of the literature that's available. What's interesting and notable is that there is a substantial body of evidence, not just in high income countries, but also in middle and low income countries. For example, the systematic review at the bottom of the screen. And again, a lot of awareness about the ways that the pandemic has increased the toll on healthcare workers. You can see, for example, the Lancet paper on the top right. And so this is, as we look to this issue, we can be considering the evidence on this. That said, there's limited evidence about burnout among other workers in the global health and development sphere. And all of us on the line and all of our colleagues are part of what I call the ecosystem of global health and development. And so as we think about burnout among ourselves, our colleagues, our teams, our organizations, we really have to understand, and I think the pandemic has underscored this, that a fully functioning global health and development ecosystem is critical to success, and we need to be considering burnout at all of these levels. Next slide, please. So I became interested in this topic several years ago as I was experiencing, the challenge of dealing with chronic stress among myself, seeing it among my colleagues. And so you can see here just some anecdotal quotations from colleagues that I've had over the years. And these are based these are from colleagues both in the US, but also around sub-Saharan Africa. You'll see quotes here from anonymous quotes from colleagues in Zambia, Kenya, Nigeria. You can see if you can guess who's from which country. In the top, I'm just going to read them out loud, starting at the top left. I think working on that last grant proposal nearly broke me. I just don't think I can keep doing this for another 20 or 30 years. I have to work over Christmas this year to respond to the donors' request for changes in our work plan. I've been here 12 years and I need to go. Maybe if they offered a sabbatical program, I would have been able to stay. I'm sorry I'm only responding to you now on a Saturday. I didn't have time to get to it earlier in the week. I feel guilty taking a vacation. Most of the time you can't totally switch off. Maybe our daughter's generation will figure out how to balance it all. We certainly have it. And that last quotation was made by a colleague about 10 years ago. I remember it so vividly. We were standing in the hallway at work and our heads were leaning against the wall. We were both so exhausted. And that's part of what prompted me to work on this. I'm going to talk about that in the next slide. But first, let's move forward. So you can see here, that's the quote. This is my daughter on the right. And as Perry mentioned at the beginning, I published a book on related topics last week. And you can see my daughter here is photographed where she was helping me with the annotated bibliography for the book. And you can see from her expression, I think she's a bit skeptical that her mom had to research and write an entire book about rest to perhaps get slightly better at resting herself. But really, on a more serious note, the quotation on the last slide, which is, well, we haven't figured it out. We haven't figured out how to achieve work-life balance. Maybe our daughter's generation will figure it out. Maybe our kids will figure it out. That just doesn't seem right to me. We are leaving a legacy for our children, and part of that has to include what I call a work-rest balance. It's wonderful that we work so hard to have major impact around the world, but again, we have to be trying, perhaps, of course, not always succeeding, but trying to model and live, again, a sense of work-rest balance. And in our case, being informed hopefully by a Sabbath ethic and by contemplative practices that we embrace as a Christian community. Next slide. So just to go back to the World Health Organization's definition of burnout, I wanted to paste it here so that we're all talking about the same thing because words do matter. And so WHO defines burnout as a syndrome conceptualized as a result resulting from chronic workplace stress that has not been successfully managed. It is characterized by 3 dimensions. 1, feelings of energy, depletion, or exhaustion. 2, increased mental distance from one's job or feelings of negativism or cynicism, and reduced professional efficacy. You can see at the bottom, the last sentence, burnout referred specifically to phenomenon in the occupational context. So that's important because, if we talk about being burnout at home or, in other spheres of life, that's okay. But we do, again, there is a body of evidence around this, and I'm hoping that we will all consider as we go back to our work, adding to that body of literature. And so therefore, we need to be careful when we use our terminology that we're defining that's consistent with what's being, used globally by World Health Organization and others. Also, just to note that burnout, of course, as it says here, is related to or stems from chronic workplace stress that's not successfully managed, which is, of course, related to mental health issues, but also to say that, of course, not all mental health issues are burnout and vice versa. And so that we need to be careful about this as we're talking with our colleagues and teams. Next slide. So why is this happening? I mean, for many of us, we've seen in our own careers how much the pace of communication has accelerated dramatically and boundaries between work and personal life have eroded. You can see here the headlines from a few newspaper articles are so poignant. Sunday night is the new Monday morning and workers are miserable. Your late night emails are hurting your team. And again, for those of us who are working globally, these porous boundaries are even more salient and notable. You can see here the quotation, "It is no longer practical for many employers to set hard limits on when staff should be reachable, since business is being conducted around the clock, often by colleagues around the globe." So we have to ask ourselves, how can we achieve balance when, again, we're all living in this hyper fast, hyper productivity emphasized culture? So let's hold that question as we think about this today. Next slide. Likewise, I loved one of the topics for the burnout session, which is, our work is good and the work that God gives us is good. So we know that our work is important. So how do we, prioritize rest and pause when we know that there's so much vital and pressing work to be done? You can see here a quotation by Bridget Schultz. She's the author of the New York Times bestselling book, Overwhelmed, and she puts it well. Mission-driven nonprofits face a particular challenge. Workers there often think that their work is so important that it matters more than work-life balance. In fact, one recent study found that as many as half of all nonprofit employees are either burned out or on the verge of this. So for those of us in this sector, this issue is incredibly important. Next slide. So why do we rest? This may seem like an obvious question, but I think for me, as I've explored this topic in my own life, reflecting on why we rest and how it is as important as how and when is an important first step for me and something I encourage us all to do. Next slide. So one of the most obvious reasons for resting is health. Sorry, the formatting has gotten a little bit messed up, so the word health is cut off, but hopefully that's clear. You can see heal. This is a paper that came out about 6 months ago. It's a really good one. I encourage you to check it out if you co-authored by WHO, if you haven't seen it. And I like it because it has both regional and global data on the incidence of overwork, which they define as 55 hours of work or more per week. And again, break that down by regional data and showing the linkages with heart disease and stroke. And so again, this may seem obvious, but we really need to emphasize that if we want to be promoting health around the world, we have to be, again, modeling rest and promoting rest as part of that. And we can't just talk about rest. As someone who's been talking about rest a lot because of my book, I was reminded the other day when I was sick, a colleague said to me, "It's fine for you to write and talk about rest, but you actually have to rest when you are sick or when you are struggling with being sick." So that was a humbling and good reminder for me. Next slide. So increasing impact. Again, there's a lot of increasing evidence and emphasis on this topic. You can see the quotation here. "Deliberate rest is a true key to productivity. It will give you more energy, sharper ideas, and a better life." So again, so many of us care deeply about impact. And so paradoxically, perhaps, we recognize that having space for rest, for contemplative practices, for free thought, actually, typically creates a greater sense of creativity and productivity, as the quotation here reflects. So as we talk with our donors and with our teams about return on investment, I think this has to be a part of that conversation as well. Next slide. And of course, faith traditions. We're here as part of a Christian community. And of course, we have the gift of Sabbath keeping, both as a mandate and as a gift from God. And again, this is something we can claim and celebrate and weave into our lives and into our work. We also need to recognize the multitude of faith traditions that offer us contemplative practices, prayer, meditation, that we can, use to inform the daily week of our cadence. Also, we've been leading at FHI 360 a staff learning exchange on burnout. And one thing that we've heard from staff around the world is that when we have crazy work hours, when we're expected our teams to work around the clock and on weekends, this can really interfere with faith practices, whether it's Muslim colleagues who are praying on Fridays or colleagues who have religious commitments over the weekend or are expecting to work on deadlines. So we have to look at this from multiple perspectives. Next slide. There are also critical linkages with rest and justice. I love this. For those of you who don't know Tricia Hersey, she's very active on social media. She calls herself the nap minister. She's gotten, again, a lot of press. You can see here, she really creates, highlights some of the linkages between what she calls grind culture and violent white supremacy and capitalism. You can see the quotation here, "Stop saying rest is a luxury or a privilege. It is not, it is a human right. The more we think of rest as a luxury, the more we buy into systemic lies. I will never donate my body to capitalism. I will never donate my body to white supremacy. Let us remember rest as reparations and rest as a form of resistance." Next slide. There are also important feminist critiques that are coming out. I certainly consider myself to be a feminist, and I realize as I've been reflecting on my own tendencies to overwork, the ways that I have subtle but pervasive connections between, workaholism and feminism. But you can see some of the new generation of feminists who are really critiquing this. The quote here, "Hustle and have it all are different in many ways, but here's how they're similar. They both link women's empowerment with capitalism, perfectionism, and elevation in socioeconomic class. The women's liberation movement of 40 odd years ago had far more ambitious goals than simply luring women into workaholism." So this has convicted me, and I think that we need to, again, think about this as we explore this topic today and in the future. Next slide. I think that there's also just really a powerful connections that we need to be thinking about who is denied the ability to rest. As we think about affordable living wages, and we often think as we think about this in the United States, when we think about the minimum wage, for example, we think about access to affordable housing or access to affordable healthcare, but also having an affordable living wage allows us to afford to time off, to take that Sabbath. We have many low-income workers who are working 2, 3 part-time or full-time jobs just to try to make ends meet. There's also people, of course, who are denied rest through the acts of violence, including acts of violent white supremacists. In the United States, where I'm from, Ahmaud Arbery was literally killed while he was jogging for leisure. Breonna Taylor was sleeping when police entered her apartment and she was shot and killed. So again, as we reflect on the topic of rest, we need to reflect on who is denied this rest that we are talking about. Next slide. Finally, a key reason for me is sustainability. I worked with a coach who once said to me, "Instead of work-life balance, I encourage asking the question, how do we cultivate sustainability? That is, what are we doing to sustain our energy? This is a dynamic process. It is not a one and done." And that word sustainable, of course, has personal implications, but it has global implications. We're all working to the sustainable development goals. And as we think about what that means, sustainable use of resources, we have to consider our own energy as a resource and how can we manage ourselves and our teams in sustainable ways. Next slide. So how do we rest? Of course, why is important, but we want to get into the how. So I just have a few minutes left. I'll move through these quickly. Next slide. Burnout is, of course, driven both by internal factors and external considerations. And I'll just point you to this resource by Johnson and Jansen, which focuses on frontline healthcare workers, but also can be useful for many of us working in the field, a conceptual model to think about these issues from multiple levels, from the individual level all the way up to the organizational, community, and public policy level. Next slide. I also really love the work of Cal Newport. Some of you may be familiar with him, and he talks about how we're living in a hyperactive hive mind, how we email and are multitasking constantly. How many of you, have you listened to this, or are at the side checking your email or your social media? We all do it. But what the evidence shows is that this kind of lifestyle is both reducing our productivity and making us miserable. So how do we really understand ourselves as both knowledge workers, as clinicians, that we need to take, as Cal Newport says on the right, we need to take seriously how the human brain actually functions and seek out strategies that best complement these realities. Next slide. So at FHI 360 and in discussions with donors, we are looking at ways that we can experiment with workplace solutions, including what people are calling structured disengagement strategies. That includes potentially having quiet or focus days, using communication tools in new and better ways, establishing clear email, meeting, and vacation protocols, potentially having closures at the organizational level, 4-day work weeks, sabbaticals, reducing workloads, and working with donors to co-create solutions. And I do think that there are exciting opportunities to do that. Next slide. So finally, I'll just close by reminding us that we have such a gift to offer the world. We've been given the gift of rest. Remember, of course, that creation was not complete until God rested. And I'll just say that in the United States, there's growing interest in mindfulness and contemplative practices, and people are taking advantage of this. In the US, the mindfulness industry is a $4 billion industry, and we have something to offer that is free and widely available to anyone, which is God's rest, the promise of this, the hope of this. And so I leave us with that and hope that we can all carry forth Sabbath rest and in our work and in our lives. And I wish you all blessings. Thank you so much for having me. Next slide. I think that's it. Thanks again.
Thank you so much, Kate. That was excellent and exactly on time. I imagine there's a lot of pressure on you, having literally written the book on rest, to practice what you preach. So we hope that God continues to have his blessing upon your work there in FHI 360. And thank you so much for sharing that excellent presentation. Our next speaker I have the pleasure of introducing is Jonathan Mwiindi. Now, Dr. Jonathan Mwiindi, he is one of my colleagues at African Mission Healthcare, has a master's in healthcare administration and recently finished his PhD in public health, healthcare management. And he is our executive vice president at African Mission Healthcare. And he has really a rich history of exposure to many, many different contexts throughout Africa, and has a deep understanding both academically and in the grassroots level of what it means to lead a hospital and a healthcare ministry. So we're pleased to have him share a little bit with us today. I hope. Thanks for joining us, Jonathan. I appreciate you taking time to do this. We're talking about leadership and governance this morning. So I just wanted to hear from you, in your opinion, what are some of the ways that we can come alongside Christian healthcare institutions to strengthen their governance and leadership?
No, thank you, Perry. And again, thank you for inviting me to be here. It's a huge privilege. And I like that first question, because you reference institutions, and we like to serve and come alongside institutions because, again, we believe they are the carriers of common purpose. So it's absolutely critical piece. And of course, we know in our settings, working with mission and church hospitals, like any other entity, we have some challenges from the governance standpoint, which I think really stems and feeds into everything else. The models, and I would say some of the things that we've seen work very well, and I can share about the things that we've seen work very well, and some caution of some of the things that we should try and avoid if possible. And are based on my experience and exposure into these church hospitals for the last 18 years. There are a few things that I've seen coming out as themes. And in some areas, we've coined this element where we have the 4 E's of governance that we like to approach and look at. And the first one is the engagement of the appointing authority of the board. I think traditionally, even for us starting on earlier on from African Mission Healthcare, there's an entry point where you either know somebody, there's a missionary who's serving there, there's the administrator, and you go in and you start having conversations about the institution and how to move things along from either making any strategic investments or partnership alongside them. And you eventually get to meet the appointing authority, but not necessarily focused or really looking forward and trying to make sure that that's one of the initial places to just see what's the vision, what's the direction, what's their sense and of the mission for the institution going forward. And then once that has happened, then we move to the second E, which is to encourage them to really have a very good evaluation of the institution, of the hospital. Which population is this hospital serving? What does it actually need from a governance standpoint? What kind of people do we need to have in the board to be able to move along the vision that he has seen, that he understands the institution to be serving? What are the strategic pillars that the leadership, the board that is there having? If there is a strategic plan, is it fresh? Is it really being used on a day-to-day basis? And then what's the leadership team's capacity? Because a lot of the times we've seen if there is a misalignment between the board that is appointed and the people who are in the leadership team, it causes for more tension. And tension is a good thing from a board. You need that because you need people to be accountable, but it needs to be structured and very well understood so that you're actually leading from an objective standpoint. And then once you've engaged the engagement of the leadership, the appointing authority is in place, and the hospital, the appointing authority has a very good evaluation and understanding of the institution, then it's to equip the board for the institution will be the third key thing. Does the board understand its role, or does it understand where the institution is going? Is there a proper induction process that has gone into play so that the board is really clear that for us, we are coming in to support, strengthen the institution from a governance standpoint by doing X. And are there periodic reviews? Is there a refresher? Is there a time where you can sit with the leadership team and agree on this or the other? And is there strategic engagement for them to know they're actually there to make strategic decisions? Because the strategic decision is more costly, like you know, Perry, more costly than an operational one. So it's very critical to make sure that this team is set up well. And some of the things, and maybe I would even go back to the first two portions to give a caution, especially if you are appointing the board, where we've seen it work very well, the appointing authority, be it the bishop, be it the head of the conference or the synod or whatever, is not actually themselves in the board. They appoint the board and the board appoints a chair who's then accountable to the appointing authority. Because once the appointing authority is there also in the board, it becomes very difficult if there is a disagreement or something that there is no clarity on an element for an escalation pathway to be clear and to be clarified. So that's just a question in terms of equipping the board. And the appointing authority needs to be involved and engaged in that process of induction and really letting them know why everybody is appointed there to have that clarity on that standpoint. And then finally,
you're saying that sometimes the appointing authority is not actually the board itself, but maybe a higher level, someone that appoints board members.
Yes.
Okay, and that could be a positive thing, huh?
Yes, we have a very good, some of our partners in the south west region in Uganda that do this very, very well, where there is the bishop who does the appointing, goes very well and really understands the institution, has a very good understanding of where the hospital is and evaluates it very well, and then equips the board and has a very good pathway of appointing board members, and he knows the number between 8 and 12 and keeps the board fresh. But he himself is not in the board. He stays above the board, and the chairman reports to him periodically and says, this is what's going. And sometimes I see the chair and the CEO come and give a report and engage him in that standpoint. I think that's practice which I hope all of our other partners could really be able to adopt. and we could adopt across a lot of the church networks that we have. And then the final E is the equipping the hospital leadership. I think whether you call them the hospital management team, the senior management team, in terms of them understanding their roles vis-a-vis what the board does, vis-a-vis what the appointing authority or the church direction is, I think is absolutely critical, because they are the ones who do the day-to-day running of the organization and need to be very well versed with what is their role. How should they engage the board? How should they keep the board informed and updated? And the word of caution here is where we've seen it work very well is that the CEO or the medical superintendent or whatever you call the hospital leader is the only one who reports to the board and is the only one who is featured on a consistent manner in the board meetings. You can call in the finance director, you can call in the medical director to come and give reports and reviews, but at the invitation. Where we've seen all these other lines come up, where it's the board that has subcommittees, which subcommittees are a good thing for a lot of the boards to make sure that they have, then they go down into the institution, and then it functionally, it becomes that the board is now the senior leadership, so to speak, and the CEO is very, very disempowered and is not able to move the ball forward, even when it comes to appointing his leadership team. And again, it's these four E's for us, we've seen them work over time very, very well, where there's an engaged appointing authority, where it's as an example of a bishop, where it's been disengaged and the person really doesn't know very much of the institution. There's a lot of tension when you're appointing people. Will they be a good fit for the board? Do they understand where the church and the organization is going with the institution that they are working with? And then an evaluation of the hospital. And then with a caution here that it needs to be an honest evaluation. It needs to be a very objective evaluation, not one that is just giving an opinion from one perspective or one person telling the appointing authority, this is where the hospital is. Do you have actually people who know how to run an organization or hospital, and do they give that honest evaluation? And then equipping the board so that they know what their role is vis-a-vis the role of the senior leadership, so that some of them know what guardrails to use and to be able to point the institution and keep the CEO really accountable in a very objective manner, not because they like him or don't like him, but because there's an agreed set of objectives and criteria. And then equipping the hospital leader. And by doing that is making sure that whoever the leader is, CEO, medical superintendent, is the one who reports to the board, and others give him input to be able to report that. And he's given authority to be able to lead his team to meet the objectives that have been laid down by the board of the strategic direction of the institution.
Yeah, I mean, I've heard and I've seen actually through organizations that we've been somehow involved with that dysfunctional governance is probably, one of the most dangerous cancers that can take down a hospital. You might have great facilities and great people and surgeons and such, but if that governance part is dysfunctional, it can really take down the whole hospital. And I think you've seen many examples, and we've talked about specifics of ones that are negative, and some of this is historical things with the founding missionary or with the church leadership. Do you have, we don't have to talk about any specific names, but any that stand out really as sort of this positive deviance, the ones that are really doing it well, and what has that meant for the institution?
Yeah, we have examples of stellar organizations and hospitals and that have followed some of these criteria. In fact, some of the thinking was observing the themes and saying, how have they managed to do this for the last 11 years in a consistent manner? And we've seen that work very well when some of these steps are there, where there's engagement, there is a really understanding, there's an insistence on a clear strategic pillars, and a strategic plan that everybody understands, that the institution understands. and a board that knows their role and is really engaged. And you sit with the board members and they tell you about the institution and the direction that it's going without referencing the document or they are reading through the document, but they really have internalized because they have an interest. And the way they have been put together as a team, they bring in various skill sets. So you don't have just everybody who's thinking on the same line, but they're actually very well put together and strengthen each other. And then you have a hospital leader who knows how to engage the board and who knows how to transmit what the board and the appointing authority or the church vision is around health and healthcare to the team, and make sure that that keeps running in a very positive way. So I've seen that, and we continue to be impressed by some that come, like we've seen on the other direction also, where the appointing authority is very disengaged or very heavy-handed and brings in just either their friends or people who are only aligned with us, they may be their denomination, and doesn't want to bring in input even within the denomination of voices that will actually be very objective and be very professional in approaching the various things. So they end up making a lot of strategic mistakes, which comes back again to your point to really mess up the direction or shift the direction or shift or slow down the development. And for us, it's not even the size of the institution, it's the potential of the institution. How is this organization functioning based on the resources that they have and the scope that they have for service compared to where they could be if governance was better? So it's not a comparison thing.
Yeah.
This huge hospital is doing very well, even though their governance could be flawed, compared to this smaller institution, which is really, from a potential standpoint, is operating at 80% compared to the large one that could be operating only at 30%, in spite of their governance.
Yeah, right.
So
right.
yeah.
Yeah.
So we've seen both sides of the equation, but I think the big thing, like you said, what we've really realized is the difference from the engagement of the appointing authority and whether they are in the board or not. More often than not, if you find them as also the chairing the board, the potential is not optimized as much as where the appointing authority themselves are not part of the board. And yeah, so we've seen many different things, but nothing surprising.
I'll be like CNN. In our last minute, we have a lot of organizations like AMH and CCIH who are on this call, who are there to help support these organizations. What are some of the key things that you think we ought to do differently than what we have historically done to help strengthen governance rather than maybe fostering dysfunction?
In the last 30 seconds, let me say this. I think the key one is focus on the institution, not on individuals. Now, I know individuals make up the institution, but let's focus on engaging the institution. And in engaging, I mean, let's focus on strengthening the institution, which also means we have to be aware when we are weakening the institution. And be very self-aware as organizations. What are some of the things that we are doing that will weaken and not necessarily strengthen?
Excellent, excellent. Perfect way to close. Thanks so much, Jonathan. I appreciate your input. And I know that comes from many, many years of experience seeing many different kinds of settings. I think nowhere does leadership get tested more than during times of crisis. And we all have experienced this time of crisis over the last couple of years with COVID. But crisis is almost an inevitable part of all work that's important, and including faith-based works. Our next session, we're going to be talking with 3 leaders from Bangladesh and 2 from Africa. Oops, that's the wrong slide. First, we have Dr. Hilary Alima, who is the Deputy Chief of Party for the Uganda Protestant Medical Bureau. And he was the COVID-19 point of care person at USAID Local Service Delivery for HIV/AIDS activities. Still the wrong slide. Kyle Scott is the executive, there we go. Kyle Scott is the Executive Director of World Mission Prayer League and Lamb Hospital in Northwest Bangladesh. He has over 30 years of serving various leadership capacities within Lamb and also with Habitat for Humanity International and USAID in Afghanistan. And Serge Batouboko, they spelled the name wrong, is the Director of Finance for Bongolo Hospital and Gabon, and has a history background in pastoral ministry as well as being an excellent administrator. So we'll move on to our individual discussions with them. My first question is, how did the COVID-19 epidemic impact the finances of your hospital with regard to cash flow, and what problems did that create for you?
I must say that at the time when we had the COVID pandemic, there was an initial scare, and definitely the effects were seen of COVID-19 in terms of the disease transmission. And the first response of the government was to lock down the country, as was happening in many other countries. With the lockdown came a critical challenge in the finances. One is that the clients that do attend these facilities were not working, a number of them. A number of their businesses actually closed down. So because the PNFP facilities do depend a lot on user fees, it meant that the clients did not have the money to pay for the user fees. But secondly, it also meant that even those that had the money, because of the lockdown, could not travel easily to the facilities. At one point, they needed clearance by political leaders to be able to just travel to the facility, to the health facility. And with this came a really big strain on the finances of the health facilities. And so we saw most of their budget, of their income going down. Challenges managing staff payments. A number of facilities actually did cut down on their staffing. And so at the level of the facility, it was really a strain and a challenge. We also saw some facilities where some of their staff were actually affected. Their families and themselves were affected by COVID-19. So if you have critical staff not able to work because they are unwell, it means that even the operation at the facility level is actually affected. And all in a lump sum, this really did affect cash flow at these facilities. So what we saw, it became a challenge for the facility to receive sick clients who can't pay and they need care, and you don't have any other source to support these clients. So that was a big challenge to most of these facilities, I must say.
Lockdowns prevented many people from accessing healthcare services and lowering LAM patient numbers. LAM remained open for business as the government exempted healthcare providers from closing early in the lockdown. And while both income and expenses lowered, the expense of salaries, which are about 65% of our operational costs, didn't lessen automatically. We had to make some difficult decisions. Additionally, some of the fund usually designated to supplement poor patient costs went to help the poor directly, making it possible for them to at least buy food. By April of 2020, LAM received donations for 3 important areas. The first was hospital equipment, such as oxygen concentrators and personal protective equipment. And the second was for community health support. And the third, funds were to be used towards operations and salaries. World Mission Prayer League, LAM's parent organization, guaranteed about $100,000 in funding for operational costs. At the same time, a decision was made by management to cut salaries. That was very difficult. In 2 months in 2020, staff at LAM, mainly outside the hospital, had between a 5% and 30% cut in salary. Many senior management staff, the finance team, and a few others continued to work full-time voluntarily, even though pay had been cut, while others took 1 additional day of unpaid leave. And in 2021, all hospital staff at increased risk of COVID, actually the Delta variant at that time, were provided a 5% risk pay. And with the onset of the Delta variant in 2021, another lockdown was instituted by the government from April through mid-August that year. Again, management decided that a 5% salary cut was necessary for 1 month. Those in risky environments are given that amount back in allowances when donations arrived that covered the amount. LAM sent out another appeal after the second lockdown was extended indefinitely, which resulted in enough income to recover what was lost in 2020 and 21. It's such a blessing to know too what we lost in income during the bad months. Generous donations covered the losses, and income has risen to better sustain the work.
Bon, mais comme vous le savez bien, c'est une situation, on peut dire, internationale. Et la situation relativement avec la COVID a impacté d'une manière très forte l'hôpital. Par rapport aux finances, ça a amené la réduction du nombre de patients. Ça a entraîné également la réduction de la circulation et du nombre de personnes qui devaient voyager pour se rendre à l'hôpital, comme plusieurs des patients qui viennent à l'hôpital viennent en dehors de notre province. Donc, à ce premier niveau-là, ça c'est l'une des préoccupations que nous avons eues par rapport à la COVID-19. Et donc, ça nous a amené à faire en sorte qu'on puisse réduire les salaires de tout le personnel de l'hôpital et certaines charges au niveau de l'hôpital. Mais malheureusement, ça n'a pas arrangé beaucoup de personnes. Donc, ces situations n'ont fait que s'empirer par rapport au fonctionnement de l'hôpital. Donc, ça nous a amené à épuiser toutes les réserves qu'on avait au niveau de l'hôpital avec l'achat de médicaments et le personnel.
So your staff were dealing with getting paid a lower salary, and they were also facing the possibility of caring for people with COVID. How do you feel like your staff then coped really during the midst of the COVID epidemic?
Bon, mais comme tout le monde, hein, on veut vivre avec des moyens appropriés et ce n'était pas facile pour le personnel. Il y a même failli avoir de mouvements, mais Dieu seul sait ce qu'il a eu à faire dans le cœur de chaque agent. À un moment donné, tout le monde a fini par comprendre que c'était une situation difficile. Il fallait se serrer les coudes et il fallait continuer à faire le travail pour lequel le Seigneur nous a appelés.
Yeah. Is there anything specific that then inspired you about the way that your staff managed themselves during this epidemic?
Oui, le premier élément d'abord, c'est notre comité de surveillance qui nous a accompagnés dans cette épreuve-là en nous apportant des moyens financiers pour encourager le personnel et pour éviter de perdre le personnel à l'hôpital. Suite à cette réaction de notre comité de surveillance, j'ai vu vraiment la plupart du personnel de l'hôpital se mobiliser et vraiment à continuer à servir le Seigneur dans cette œuvre.
Yes, I think initially most of the staff feared actually to go to hospital because of the safety issues. I must say in Uganda there was a big challenge in terms of personal protective equipment. So the masks, the protective gear, the temperature guns were initially not in place. A number of facilities were actually not ready for that kind of pandemic. And because of that, at the facility level, there was a risk. And especially when the staff started contracting COVID-19 from the clients, and we lost some staff, I must say, to COVID-19. And so when that starts to happen, there was big fear. And a lot of the staff actually said we can no longer see patients. And especially for patients who had cough symptoms and symptoms similar to COVID-19, even if it was TB or hypertension, no one would want to touch you. People started asking for risk allowances, but remember already the facilities are having issues with their finance. So when you begin to ask for risk allowances, that kind of money is not available. Most of the facilities really did call for help in terms of being able to train and sensitize the staff, trying to make their environment even better. In terms of culture, like you say, if you look at the way PNFPs do operate, there is a culture of the way they offer service. It's not just like a job. It's like a ministry. It is like a mission. It's like you are, yes. So that's how they feel about it. And so as facilities, we have to sit down and see how we organize transport to pick staff. How do we provide how do we support the staff to be able to work within this very difficult situation? And so, yes, indeed, the staff morale was affected, and some areas of the culture of operation were indeed affected at the time.
Actually conducted staff morale surveys in late 2020 and early 2022 with specific questions related to COVID-19. Questions were designed to ascertain what staff understood about COVID-19, and that ranged from causes of transmission to staff's understanding of health-related protocols that were put in place to mitigate the spread of serious illness. Amid the initial panic, a few brave staff took the task of working in the COVID isolation unit. We praise God that outcomes in our area were relatively mild compared to in other countries. Had the pandemic led to more serious illness in our area, perhaps the results would be different. 89% of staff listed an increase in financial problems and concern for elderly parents during the first phase of the pandemic. Very few actually listed mental health effects. Staff were generally positive about there being soap and water available, but less positive when asked if there was adequate protection provided in the workplace. 40% of staff said that they were never afraid to come into the office because of work during the first wave, but nearly 1 in 4 said there was a time where they were afraid but no longer. And in a recent annual general meeting, staff responded to a question as to what challenges they faced or what they learned during COVID. One staff member shared how his hygiene had completely changed. He believes that helped him stay healthy. Another expressed how strong the stress was for him and others, and how it led to a real fear of death for so many. One LAM nurse of another faith who became seriously ill and almost died with COVID expressed how grateful she is to God and the Christians for the loving way they provided for her when she was admitted to our hospital. She thought she would be isolated and not be able to see anyone, but she was surprised at how much personal love and attention she received from LAM hospital staff. I believe that having times of sharing among our staff in our morning prayer and devotions has helped everyone cope better than they would have otherwise. Many of our staff felt very blessed that they were working with LAM at this time, because so many workers in other organizations lost a tremendous amount. The knowledge of how staff of other organizations were impacted definitely helped LAM staff morale overall.
Finally, what leadership challenges did this create for you as well as the other leaders in your hospitals? Tell us about your successes as well as your failures.
I have to give credit to God and to our leaders of LAM who really rose to the occasion in a highly fluid and complex situation. There were many challenges, some of which we really still haven't found solutions for. There was considerable tension among management staff during the months after the pandemic and lockdown. Everyone was stressed due to personal and work-related issues. Tension came to the surface occasionally. There was a sense of vulnerability because we hadn't experienced this before. While there was some teamwork, it wasn't as effective as it might have been. And the situation in the hospital was vastly different than other parts of the organization. The hospital, in coordination with LAM's operations team, implemented a new isolation ward, made their own personal protective equipment, ordered new equipment, focused on contingency planning and financial planning, took time and energy. They developed remote working policies for staff who could work from home, and they gathered information from other practices of other organizations. Frankly, this effort really had several challenges, including very negative opinions by management and about remote working, as it's so difficult to monitor. And there really isn't a culture for this in rural Bangladesh, and many staff were found abusing that privilege. Some jobs just cannot be done remotely, such as patient care and housekeeping services. And the decision to reduce non-essential LAM staff during the lockdown was extremely difficult, causing a major leadership challenge, and effort was made to ensure that lower paid staff weren't unnecessarily harmed. Generally speaking, staff were very gracious. Hospital leadership was challenged to educate all staff on infection control to a whole new level. And unfortunately, we did have several doctors resign immediately following the start of the pandemic in 2022, presumably out of fear or to meet the demand of their family members. Doctors and other healthcare professionals who have stayed have shown great character. Interestingly, no Christian doctors resigned. More recently, LAM has provided the Bangladesh government free support for COVID vaccination distribution. We're paying for the transport of vaccines and for food allowances out of our pocket. This type of support for the Bangladesh government initiatives provides a win-win situation for LAM. It's the respect we gain from this is significant, and we depend on a good relationship with the government to be able to carry out our mission.
Yes, I think drawing from some previous examples, some of the leaders really did stand out. I think previously when we had an outbreak in northern Uganda of Ebola, we did have examples of leaders that actually stuck in, even in the toughest moments, very little experience on how to manage a pandemic. They did actually stick with the staff. And we saw some of them, unfortunately, lost their lives, but there are those who lived to tell a story of how to manage in such a difficult situation. So there was a lot of learning to draw from the past experience. And we did see some leaders really stand out even this and stayed at the facility even initially when there was not enough, PPE, not enough resources, not enough information and knowledge on COVID-19. I know at the beginning, even for WHO, the information was scanty. And so even when you go online, there was not very clear information on how to manage. And so we saw some of these leaders stand out and with a little information, limited resource, be able to bring their team together and say, this is what we know for now, and this is what we can do for now. This is how we can stay safe, and this is how we can support our staff. And for those facilities, we did see services happening and also see clients begin to aggregate towards such facilities because, if a public facility has closed down, they probably feel no obligation to continue working. For the PNFP facility, we have to set a different example. This is missionary work. And then we've learned from before that we can actually stay and be able to offer services. So yes, also advocacy from these leaders to government institutions, to the district leadership for support for this facility. We saw that coming through. And then even when the district leadership was setting up task forces to be able to address the challenges of COVID-19, they did participate, and some of them took actually lead at the district levels in terms of interventions for in response to the COVID-19 pandemic and its effects.
Bon, la leçon que j'ai pu avoir de cette situation, c'est comme la Bible nous le dit au sujet de la veuve de Sarepta qui était arrivée à un niveau où elle n'avait plus d'huile. Elle a dit à l'homme de Dieu que la nourriture qui me reste ne va servir que pour l'enfant et moi, et puis après nous allons mourir. Mais chaque jour, on a vu la main de Dieu intervenir dans la pensée des leaders de l'hôpital, du comité de surveillance, de nos donateurs, pour nous appuyer dans l'achat de médicaments et dans le soutien des pasteurs. Vraiment, le soutien du personnel au niveau de l'hôpital. Et cette histoire-là m'a beaucoup marqué pendant ce temps. Et c'est l'une des leçons que j'ai pu tirer.
My last question is, if there's been any way that the COVID epidemic has strengthened the hospital for now or for the future?
Bon, à mon avis, oui. À mon avis, oui. Oui, dans quel sens? Dans le sens que le fait que vous ayez des partenaires comme vous, qui sont des partenaires qui écoutent et qui vont aux besoins des organisations dont ils veulent accompagner, ça, c'est une des premières bénédictions que j'ai tirées de cette crise. De voir que ceux qui sont à des milliers de kilomètres que vous, Dieu va les parler, Dieu va les convaincre, les amener vers vous pour qu'ils puissent répondre aux préoccupations auxquelles vous êtes confrontés.
Thank you so much to all of our panelists for their presentations. We have all but Pastor Serge who have joined us for the question and answers. If you could think through some questions that you would have about leadership during the time of COVID, we'll have an opportunity for them to address those at the end. The next section, we're going to have a discussion about the ethics of leadership and governance, and we have two great presenters for that. We have Dr. Paul Hudson, who I've worked with for many, many years. He's a physician and epidemiologist and has spent his career working with SIM in Ethiopia, Nepal, as well as Thailand. He's had the privilege of serving on both patient care as well as disease prevention, also being a public health person. During recent years, he's focused, his focus has been on leadership development, especially at the intersection of health and the gospel. He's been one of the team that's helped to put together a new curriculum looking at healthcare ministry. And I really appreciated his perspective. Next, we have Kate Michelle Desjardins, a board certified chaplain, and also the director of the Mennonite Healthcare Fellowship. Kate is passionate about integrating spirituality, faith, and theological ethics into healthcare at all levels. She serves on the board of the International Joint Council for Spiritual Care Research, and she's also a co-pastor of the Germantown Mennonite Church. So without further ado, I'll turn it over to Paul and Kate. Welcome.
Good morning, everyone. And it's great to be with you. Thanks, Perry, for that and for those amazing presentations. Hi, Kate.
Hi, Paul.
Yeah.
Hi, everyone.
So Kate and I agreed to have a little conversation, but I'm asking the questions and she's providing all the answers. So Kate, we just saw we heard Jonathan, for example, amazing principles of governance, and we've heard from these leaders who talked about the crisis of COVID and some passionate, some inspiring things. So I'm going to try to dig a little deeper into the ethics, since we are all about following Jesus, doing what's loving for our neighbors. So you've seen Christian, mission, Christian organizations. You've seen different Christian healthcare organizations. What do you see as the foundations for ethical governance and leadership?
Absolutely. I think a lot, and you've said it, our mission is at the heart of what we do. In a lot of Christian organizations, and especially Catholic organizations, the phrase mission integration or mission formation is used as how we keep that mission kind of front and center in all we do. I was lucky enough to spend a lot of time in a monastery many years back and on and off since then. And the rule of life there, it's Grand Champ, which is outside of Geneva in Switzerland, opens every day with, in French, it's Prie et travaille pour qu'il règne, or pray and work for the coming of the kingdom is how I like to translate that. And that is the heart of Christian ethics to me. It's that is everything we're doing, from the emails we're sending to the ways we're interacting with patients, and especially in governments and leadership, to the ways we're interacting with each other and the ways that we're shaping our organizations, is that showing and paving the way for the coming of the kingdom of God through the ministry of health. It's not the only way the kingdom of God comes, but it certainly is one, right? Like, we believe that God's presence is a presence of health and wholeness. I think about that a lot. And a lot of ethical things that get brought up are things like managing of finances. And I think that Christians, with our long history of doing money differently, of doing money in a way that simplifies things, that focuses on the other, that doesn't accumulate in the capitalist mindset, have a lot to say for that. But one of the things that I am very aware of in Christian organizational governance is the tendency to drift a bit from that core mission of pray and work for the coming of the kingdom, and to get really caught up in the day-to-day and the sense that we have to do it all ourselves. And we forget sometimes that even within an ethical framework, God is helping us to be ethical as we're relying on God. I know I tend to want to have these sort of clear statements of ethics, and I think that's a very good idea. If organizations don't have an ethical code for their operations and separately an ethical code for their leadership, I think that's the first place to start, is sit down, have those meetings, put some things on paper, but then continue to revisit them. Don't just put it on paper and file it away in your email or in your closet. Revisit that and make sure that those ethics for a Christian organization are rooted in scripture. I love ethical statements that have the ethical reason why we'll do something and then a scripture on the other side that shows that this is part of our tradition. But beyond that, I think it's so important for organizations to keep their mission in front of their leaders every day, whether that's opening every single meeting with a story of something that the organization is doing on the ground and a prayer, or simply rereading that mission over and over again. I think that actually gets to the core of ethics. I could sit here and I could say, do this or don't do this ethically, but I actually think that ethics is a little bit fluid. What each organization will do that is ethical is going to be culturally dependent, and it is going to be missionally dependent. What is the mission? And keeping that mission in front of us is a challenge at times, but I think is at the heart of remaining ethical.
So thank you. So this drift that you're talking about that might happen, like how does that begin? How can we prevent that kind of drift away from the mission of loving our neighbor, following Christ, and into some other realm?
Yeah. I noticed that with leaders on the level of governance at the executive director level, at the director level, and even the manager level, in many areas of missions and of healthcare, tend to not have as much interaction with the folks served, what we might say on the ground, or what we talk about frontline workers in the pandemic. To me, one of the first things that we can do to hold that mission drift, aside from what I've said before, which is bringing it up constantly, I like to say mission should become almost obnoxious because it is that important. For instance, there's a large Catholic healthcare organization that I work with here in the US, and they always start every meeting, even if it's a 25-minute meeting, with a 5-minute reflection. One person talks about what the mission means to me. And that helps every meeting, whether it's in the people that create their electronic health systems, are actually some of the folks that know the mission better than even some folks on the ground because they have this practice. But the other thing is, I think it is so important for our leaders and those who are creating policies to spend as much time as possible in healthcare, with patients, with clients, with those frontline workers, really hearing about what they're facing day to day. I am a board certified chaplain, and I spend a lot of time thinking about governance and the leadership and management of chaplaincy departments, which tend to be religious departments within secular organizations, not always, but often. And even there, where we think of chaplains as being very close to our patients, I find very few chaplain managers spend time doing clinical work actually with patients. Because, as I think Kate talked about earlier, the workload is so heavy that it feels like an extra to leave our emails. Maybe if we're managing from the other side of the world, which is not uncommon in missional governance, to fly across the world. And there's questions about climate change and carbon emissions and all of that. But on Zoom, it's so easy to stay here. And I think that avoiding that mission drift involves really being sort of on the ground with folks as much as possible. The other thing that I think about in terms of avoiding that mission drift, and I mentioned it earlier, is the importance of constantly maintaining a sense that it is us working together with God. And again, this goes back to Kate's presentation. Rest is a human right. God rested. We are not in this alone. If we are called, then we know that God and the Holy Spirit and Christ are with us in our work, and it doesn't all rely on us. And taking the time to recognize this, I spend a lot of time with some work by someone named Ken Pargament. He's a psychotherapist. You might not think it applies, but he's done a lot of work on how we cope using religion. So cope with anything from COVID-19 to our jobs, how we use our faith to cope, and how certain religious coping styles actually translate to better human health. And the coping style that translates the best to human health is called collaborative religious coping. I will put some of these papers, they're a bit academic, but I still love them, in the chat after this. And collaborative religious coping is really saying, I have a role and God has a role. It is not up to me, and yet I will take the responsibility. I will send the email. I will think about the ethics. I will do these things, but it's not all on me. God is playing a role, and I'm looking actively for the ways that God is engaged in this as well. For me, I think that is something that we need to keep in front of us and think about. Am I being collaborative with God today? As I'm making this new policy, how am I looking for the ways God can be a part of this as well? It seems simple, but it's not always in our busy world of mission and of healthcare.
Yeah, it seems so. Rest is not, and preventing burnout is not just getting away from the work, but it's finding somehow that rest in the work, is what I hear you say, whether that's, kind of the, walking around, managing by walking around and getting to know our people, or whether it's sitting on a board and being in meetings or whatever. It's so easy. Like the folks that are listening today are likely very, very busy and very involved and really out there, but to know that Jesus is in the middle. And they're part of a greater mission that he's doing, really is liberating and inspiring, and gives the energy. Thanks. It gets back to your initial thing of mission. Any last minute? We have a minute left, so anything left? You've said everything, so I doubt there's anything left. But
I think the last thing I would add is the importance of evidence-based practice. This is a key word kind of floating around in healthcare, but I really think that in any health mission, healthcare organization, focusing on evidence-based practice is key to being ethical. Evidence-based practice has 3 interlocking circles, and one of them is the cultural environment and the beliefs of the practitioner. So it's the research-based evidence on a health issue or even on leadership and governance, but also the culture and beliefs of the practitioner, and then the needs of the client. So it's not this cut and dry thing. It has this interaction, and I like to put a line in my sort of diagram, and the Holy Spirit kind of surrounding all of it as well. The Holy Spirit can be in our research papers, it can be in our evidence, it can also be in our discernment. And so I think about thinking about the ways that as a missional organization, we are also incorporating the best evidence for whatever it is we're doing, whether it's leprosy care, whether it's mental health care, whether it's chaplaincy and spiritual care. That to me is the last kind of piece of the puzzle, I think, of being a truly ethical organization.
Thanks so much, Kate. I think all of us would like to spend a little more time with you over after this, but somehow the Lord may let that happen sometime over the next weeks or months. Thanks so much.
Thank you so much, Paul. This has been a delight.
Very.
Thank you so much, Paul and Kate. It reminded me, actually, I love the comment that you made, Kate, about the disconnect sometimes that leaders have between what they're doing as an organization and the end beneficiaries of their ministry. And I saw that happen in my own work when I was in Malawi. that I really needed to be hands-on doing patient care. And that's what really kept me focused and on mission. I remember one time I was visiting, actually, I think it was somehow connected with CCIH, visiting Washington, D.C., and had a chance to visit with DHHS, people who were working with PEPFAR. And we were presenting what we were doing with HIV/AIDS and sharing some stories of lives that were being saved through medications. And I had the great privilege of being able to thank them for their hard work behind Excel spreadsheets and proposals and stuff, and making that connection for them to be able to see that the things that they're doing and stressing over are having a beneficial effect on the end beneficiaries. And I think that's something I would really encourage all leaders who are on the call, is to make sure you're taking some time to hear about, and even better, be hands-on with some of the people who are being impacted by the work that your organization is doing. It really helps offer that sense of meaning and purpose, helps you stay on focus and stay encouraged. So we'll move on to our next section, talking about how effective is your organization. Find out with faith-based organizational capacity assessments. So I'm going to be handing this over to Doug Fountain, who may not need introduction, but he's our executive director of CCIH, and he'll be moderating this next section. Doug, did you want to do the introductions, or do you want me to do those?
Sure, I can do those.
Thank you. It's all yours.
Great. Well, thank you, Perry, and really appreciate it. And what an exciting day this has already been, to hear such wide perspectives on everything from rest to governance to just the practical side of leading through crises, leading ethics and leadership. Perry, I appreciate your comments there moments ago. I'm really challenged, and as somebody who leads this organization, I've found myself continually thinking through, are we resting? How are we doing on governance? How are we really thinking through all of these different things? And so it's fitting now to turn to something very tangible, which is to talk about how we assess our capacity as organizations to do those things that are our mission that Kate was speaking about so clearly. I'm delighted to have a panel with three people today to share in this with me. Dr. Dennis Chirian is Associate Vice President, Senior Technical Director for Health and Nutrition at Chorus International. He oversees all of the health, nutrition, and WASH work there. And Martin Oluch is the Health Systems Strengthening Advisor at ACHAP, the Africa Christian Health Association platform. He's also the technical lead for the Capacity Strengthening Initiative at IMA World Health-led, USAID funded Momentum Integrated Health Resilience Project. And so he's a specialist in that area. And then also for Florence Bull, who serves as the health coordinator and operational head of the Secretariat of the Christian Health Association of Sierra Leone. And each of us have something different we're going to address during our time. So I'll give a little overview of what CCIH is doing in terms of organization capacity assessment. We'll turn it over to Dennis to talk about why this is important. We'll hear from Martin as they have rolled out a project to assess capacity of organizations, and then complete with Florence, who will give us a sense of how that's actually gone in her situation. So let me set some context for CCIH's interest in this. I think it's no surprise to all of the people who are participating that CCIH is passionate about strengthening the capacity of local organizations. And that cuts across a lot of different sides and facets of organization capacity. We really spend a lot of time around that. But a few years ago, we realized that there were no widely accepted tools to help you assess your own strength. And we set out to try to address that by creating something, and I think we can show that slide now, CCIH actually worked with, we're working in a few of the USAID funded new partner initiative programs and developed an organization capacity building tool that that has a couple of key features. One is there's a preliminary part of the capacity assessment that indicates whether an organization is ready for donor funding. It's about donor readiness. And so it's a very simple screening tool that you could use to assess whether you are really on track to be able to partner with donors. But then the comprehensive assessment is for overall capacity strengthening, an overall assessment of how you're doing as an organization. The domains that we looked at, in developing this tool, we looked at a number of different tools that are in use and tried to figure out which is the best approach that fits our context and our membership, and landed on these key domains: governance, management, operations, human resources, finance, fundraising, communications, advocacy, network, and program. And I slowed down on those because sometimes those are missing in some of the other assessments that we see. A lot of the assessments focus on governance or finance, but they sometimes miss the communications and advocacy. How are you expressing yourself in policy processes? And then network performance. How are you as an organization actually improving effectiveness of the cooperation and integration across multiple partners? These tools are designed to be self-administered. They're all anchored. And by that, I mean, there's an example at the bottom on budget and cash flow planning. It shows that they go from low or no capacity, and organizations rate themselves all the way up to strong capacity. And it ranges from, at low, they have rough budgets that are only periodically reviewed, all the way to the other end where there's monthly review of cash flow. And the detailed financial analysis is used for detailed planning. And that, so across all of these different domains, then organizations can put in a score into an Excel worksheet, generate some rankings, and internal rankings, and then decide where they want to put some attention. And then there's a capacity improvement action planning tool that they can use then to help indicate what their concrete action steps will be to improve. So that's what we're doing. But I wonder now if I could just turn it to Dennis and talk a little bit about what's the importance of this. Give me a sense of the context of why this is important for our field at this time. Dennis, over to you.
Well, thank you so much, Doug, and good morning and good afternoon to everybody else who is online. Well, from a Cora's perspective, model of work has always been working through local partners. That has been its history for the past 50, 60 years. But what has happened in the course of which is, we realized that we have not documented that properly. So we went ahead, I undertook an exercise to try to capture and document our work, in the process of which we articulated what's our capacity strengthening framework. I like to use the terminology strengthening here rather than building, again, because it makes the assumption that every organization has capacity and you're not trying to build, but strengthen them. And I think that's a very important distinction. But if you look at this pillar here, if you look at this pyramid here, you will see at the top is to deliver, which is very important. And that's what gets prominence all the time, which consists of the technical skills and qualifications an organization requires to deliver its programs and achieve results. So what does that mean? That means maybe you have health systems strengthening capacity or infectious disease expertise or monitoring, evaluation, etc. And that's integral. That's important for every organization. And the next one you will see to the left in the corner is to organize. Those are basically the processes and structures that an organization need to have in place so that they can execute their programs well and manage them effectively. right? And they include things like, do you have human resources in place, procurement systems, financial management, all of those kinds of related things. And do you have new business developments, skills, grants management, etc. All of those skills that are required for an organization. Now, they're all what most people do and all of us want to do, right? But as already indicated, they are all geared towards a lens of risk management, delivering to what the donor requires. But we want to go a step further. And so you will see on the right, it includes things like relational. And how do we capture and document that? And that includes, do you have the right leadership, the stakeholder engagement, social capital, your ability to cultivate donor relationships? All of these are integral for us to achieve results. You don't burn bridges and achieve results, right? So how do you relate to your peers? How do you relate to your communities? Those kinds of skill sets, and trying to measure that is what they relate to. But when you look at the heart, which is to commit, those are the values and mindsets. Most organizations are not trying to measure that. But what we want to do is that look at our organizational culture and confidence. What's our ability to adapt to issues? And what's our continuous learning and performance culture? Do we have mechanisms in place? And for Christian organizations like us, we can always measure that also from a faith perspective. For example, looking at holistic health. So how do we define problems and common interest? Or how do we present a shared voice within church and outside as well? What are our Christian ideas and values of compassion or accountability? Those are things we are trying to measure that. So it's an early phases trying to capture that using a faith-based attributes tool. But when all of these together works, that's when an organization is effective, sustainable, and can create the impact, and not an organization that is created to manage a grant, which is also important because we live in a world that is competitive. But at the same time, they don't define what makes an organization and its identity. And so that's what we are collectively trying to work together and trying to make that distinction of having all four elements working together to achieve the goals and sustainability we all aspire towards. Thank you.
Yeah, that's great. That really sets the importance and the context for this work. Now let's transition from that to Martin. Martin, can you give us an idea of what's happening within ACHAP and how you're taking this on now? Please, over to you.
Thank you very much. First of all, thank you for bringing me into this important discussion. I want to start by saying that one of the key mandates of ACHAP is to support its network members to strengthen their capacity to deliver their mandate, and also to support their members who are delivering services in their own organization. So we've been doing capacity strengthening for a number of years, but we've had a lot of learning and lessons. And this has informed us in the way we have engineered our guiding principles, our capacity building processes and approaches. I want just to, I think we all know about ACHAP, but ACHAP is a regional based organization that started in the year 2007. We are based in Nairobi, and we have about 43 members who are in 32 countries. Next slide, please. Last year, we received some funding from IMA to support a number of CHS. We identified 7 through a competitive exploration of interest. Currently, we are working with 5, Malawi, Nigeria, Sierra Leone, and Ivory Coast. In Cameroon and DRC, we are supporting them to set up a CHA. They don't have an active CHA in that country, so we are supporting them to set up a CHA. We received some small grants that we are using for this process. Next. Of course, we all know that for you to do an effective capacity strengthening, you need to identify the areas of opportunity. You need to identify the gaps. So we adopted the CCIH Comprehensive Organizational Capacity Assessment tool. This is the tool that we use for our assessment. And we really engaged the CHS before we started this process. We shared with them this tool so that they knew in advance what are the issues that we are talking about. We had a series of meetings to explain the objectives of this project. We discussed the assessment tool. We also explained them the process that we are going to involve. Of course, this is a self-assessment tool, but due to logistics issues and resources, we made it a purely self-assessment where we allowed the members to take the tool and go with it in the organization, engage members, engage staff, and do their own capacity assessment. And we really emphasized the aspect of as many people being engaged, because we do not want a situation where the tool is taken by 1 or 2 people and then they check it off. So we actually gave them time. We asked them, you take your time, engage everybody in your organization so that what comes out is some kind of consensus. Next. At ACHAP, we look at assessment more than just identifying the gaps. We think the proper assessment and a proper assessment tool provides a tool that starts honest and discussion about the structure, systems, and process in the organization. It brings out an avenue where organizations can come to a consensus on what challenges they are facing, what are the opportunities they are facing. So it's not purely just looking for gaps. In fact, we encourage them to take an appreciative approach where we don't only look for gaps, but we also look for things that are working, things that we can institutionalize, and things that we can strengthen in the organization. I was happy that during this process, leadership of this organization came forward. In some of my meetings with them, discussion, I saw the Secretary Generals and very senior staff members being involved in this process. So most of them have already filled this tool and they have shared with us their results. Next. The next was to develop a capacity strengthening plan. As you are aware, the CCIH tool also has a template for developing a capacity strengthening plan. And we found it extremely useful because we moved away from the traditional setup where you have a template of activities, when they will be done, and who will do it. This tool was very useful to us. We found it very useful to us because it interrogated the organizations during the planning stage. It will ask you the prioritization of that activity. What is the goal and the objective of what you are trying to do? What resources do you require? We are just moving away from the mentality that you must have funding to do any activity. There are very many activities that we can do within the organization using our normal LOE and other resources. It also asks about partnerships. Some of these things you may require internal and external partnership. Who are the people who we can bring in to help us achieve this objective? Then it also provided opportunities for follow-up. So this was a very comprehensive capacity strengthening tool. Of course, we also encourage them to focus on a few. Effective capacity strengthening is where you focus on a few priorities so that you can have maximum impact. But we also told them that we must not only plan for donor-driven or externally driven capacity building. We also need to look at the organization in a comprehensive manner so that we institutionalize, we make this part of our organizational structure. So we are actually trying to make sure that our members institutionalize capacity strengthening and not wait until a donor comes and demands for assessment to be done and a capacity strengthening to be planned to be developed. Next. During this short period, this is an ongoing project. We have learned a few things and we are making a few recommendations. And this is something we are working with our members on. First, we need to institutionalize capacity strengthening. Let this be part of what is happening in the organizations, just the way we have HR, finance, program management. Number two, we also need to use capacity assessment as routine reflection of what is going on in our organization. Let us not wait until we have a capacity strengthening plan. This is something we can do annually so that we reflect on what's going on in the organization, what is happening in our environment. What are some of the opportunities that are available? It allows the organization to have a common understanding of the challenges and the opportunities that exist in the organization. Right. Then the one that was also mentioned, let capacity strengthening be inward. Let us not wait until it is demanded from outside. And then the other thing that I also mentioned that we are also encouraging is that we want capacity strengthening now to be something that is routine within our members. They can budget for it using local staff and also using local resources. But before I finish, there's something that I also wanted to bring out.
But Martin, you wrap up very quickly because we want to get to Florence too.
Yes, this had been mentioned by the first speaker, is that we are now focusing on what is called the soft skills. We are moving away from those traditional capacities. For example, things like fundraising, communication, advocacy, networking. These are the skills that allow us to expand our footprint in the national health system. These are the footprint that allow us to gain social capital. And these are the footprints that also help us to project the work that we are doing outside there. Thank you.
That's really important, and I appreciate your setting that in context also, and the value that we bring in is not just to meet donor requirements, but to internalize this and also address soft skills. Now, with that in mind, Florence, can you give us some perspective of how this actually worked for you at CHASL? How did you go about this, and what can you share with us, please? Over to you. Hear you, Florence. Florence, we can't hear you.
Hello, can you hear me?
Oh, I hear you now.
Thank you. Good afternoon, everybody, and thank you so very much, CCIH, for giving CHASL this opportunity to use this platform to share experience and know much more around CHASL, about CHASL and the work we do. So as a brief background for those who don't know about CHASL, CHASL stands for Christian Health Association of Sierra Leone, and is the technical coordinating body for 43 health facilities across Sierra Leone, and has been in existence since 1975. That's around 47 years. So at 47 years, we have gone through the journey from baby stage to maturity, and we have had a high and low periods. We have also moved from a stage of fragility, and we are moving now towards stability. As we go along our institutional life stages, we continue to reflect, review, restructure, and rebrand, and also finding ways to continually improve, maintain, or sustain against meal throughout the years. As a visionary leader, you need to set targets and benchmark for improvement and continually evaluate this progress or impact. You also need to pause, reflect, come back to the drawing board. You cannot do all of this without a structural tool to guide this process. And that's where the organizational capacity assessment comes in. I first got to know about the organizational capacity assessment tool when I was asked to provide my technical expertise on RMNCH in the area of the organizational capacity assessment as an implementing partner on the ground under Momentum Country and Global Leadership. That is a USAID funded program for a new partners initiative, that the Sierra Leone Midwives Association. PAT was leading this, and CHASL was subcontracted by CCIH as an implementing partner on the ground. I became very interested in this tool, especially when I was privy to go through this tool before the activity. I know this tool will add value to our institution, especially the stage where CHASL is, at the stage of rebranding and engagement with new partners. So I seized this opportunity and then help us as an institution to be better poised to be a better institution. I went through the workshop fully engaged and with an expectant and eager heart to learn more about the process and see how it can be applied to CHASU. It was very eye-opening and revealing, and the experience resonates more with the Bible verse of Matthew 7 verse 3, which says, "How will thou say to thy brother, let me pull out the smooth out of thy eye, and behold, you have a beam in your own eye." It's like taking the speck of the brother's eyes when you have a log in yours. But the difference is that you have this burning desire to move on. So that's propelled us to seek support, and we made this desire known to CCIH, who asked PACT to see how they can support us to go through this assessment. Another area that is equally important is to ensure that the action plan are implemented to the full to realize its worth. So we went through the assessment with PACT, but at the time there was no fund under the MCGL to support the action, but we keep pressing. One thing that struck me and was very revealing as a leader was going through the assessment with the team. So it's not that just the other staff were there, but we were there as a leader, senior management, we also part of the exercise. I can clearly remember when we were going through the practical exercise about governance, leadership, vision, and policies of the institution. Staff were asked to step in a different ring to see whether the statements reflect the true or not true picture about the institution. I usually stayed back just to see where staff will go and not just to toe the line as if I have gone there ahead of them. I got to know that staff had different and completely views on the basic fundamental principles, which leaders take for granted, thinking that we are all on the same page. So this practical exercise with the team was very revealing, and it shows some of the gaps in the communication within the team, which needs to be addressed for the good image of the institution. As Martin has already said, there are some variation with the tools and some adaptation which will be suitable based on the type of institution you find yourself. The OCA by PACT is more general and suitable for most institutions. But for organization or institution like the Christian Health Association, the CCIA organizational capacity assessment suits mostly, and it have domains for network effectiveness and viability, and also the scorings are different. So depending on the institution you find yourself, so you need to look at this and then have it suit you. And there's also the faith assessment tool by CCIH, which is very useful for standing as faith institution, and also to bring us back to our mission, to remind us of our mission and identity. It might not be 100% prescriptive depending on our local context or the situation that we find ourselves, but we need to have a balance between mission, charity work, but also looking at an institution for not a loss, but not also for not a profit institution.
I think that's a great place to wrap up there, Florence. And I know we could talk a lot more about that, but we need to move to Q&A, and some of the things that you're going to be bringing up after another session, I know, but maybe some of these other points can come up in the Q&A as people probe your experience after this. Really grateful for your perspective. Grateful, Martin, for your experience rolling out through ACHAP. Dennis, thank you for sharing with this. Let's go ahead and pause there, and we can pick up some of this, I think, as we move into the next session and then into the question and answer. Thank you, Florence. Thank you, Martin. Thank you, Dennis.
Yeah, we do have a number of questions that we'll be asking in the Q&A session that'll be interesting to hear back from. Our next session, we're going to be talking about a committee that we have with a working group within CCIH. It's called the Governance and Leadership Working Group, which I have the privilege of serving. I'll say under Janelle, because she's really our inspiring leader. And I wanted to introduce Janelle Williams. She has an MBA and serves as the Director of Global Health Action, developing programs and partnerships to strengthen health systems and community systems, excuse me, in low and middle income countries. She's currently working on her doctorate in public health and has a lot of energy and experience to share with us. So Janelle, you could just tell us a little bit about CCIH's Leadership and Governance Working Group and why people should be a part of it.
Fabulous. Thanks so much, Perry. And what an awesome morning it has been, afternoon and evening in some places. So just in the next few minutes, just wanted to invite folks to consider joining our working group. Certainly Perry is a co-chair, and we also have another co-chair, and I'll share that in a little bit. But if you wanted to get a deeper dive into some of these conversations and to really begin thinking about how do we work through this throughout the year, please consider being a part of this group. We started in the latter part of last year in 21. And our goal is really looking at how are we strengthening health systems through inspiring transformational leadership, strengthening good governance, developing quality evidence, and supporting local solutions. We can go to the next slide. And so what we're looking to do is by the fall of 2023 is to focus on two sort of big areas within leadership and governance. We certainly can't do everything, but as a working group, the idea is that we'll pull together the collective knowledge. I mean, so grateful for Martin, who's a part of the group as well, and so many others. But looking at these two overarching areas, one is to promote, and the other is to generate and disseminate evidence. So promoting the leadership, good governance, and healthy organizations in low and middle income countries. And so how we're looking to do that, at least for this next year and a half, is to say, how can we help to develop a hub of innovation? How can we use our regular meetings to do that? How can we conduct periodic webinars? We're doing twice per year. We just completed one, our very first, which is looking at the business case for faith-based organizations. And then developing and implementing a CCIH peer mentorship program, which is already underway. We're starting with Kenya, which is really exciting, and partners within ACHAP. We're looking to generate and disseminate evidence. So a lot of this is how can we begin to add to the body of evidence and increase the awareness of what's actually happening within the faith-based sector as it relates to health, leadership, and governance. And then we're also working on identifying practical challenges to implementation, which a lot of these sessions prior have focused on. And then, of course, looking at how we can take that knowledge and how we can take those learned lessons and begin to develop policy briefs, and how can we help to inform local and global health advocacy. If we can go to the next slide, please. And so our group is actually led by three fearless leaders. Perry Jansen, as you are all familiar with from today, Vielwa Chitimbre, who is of ZAC, the Zimbabwe Association of Church-Related Organizations, and of course myself with Global Health Action. And so we meet every other month as a larger working group, and it's 10 a.m. Eastern Standard Time. And then in between those sessions, we actually have subgroups that actually work on the particular areas and the goals that we've collectively come up with. And so overall, what is it that we're attempting to do, and who are we, right? So the Leadership and Governance Working Group will be a hub of innovation, providing relevant resources and active engagement to strengthen health system leadership and governance among CCIH partner organizations, and to also support the work around 30 by 30. So if you're interested, please feel free to join by emailing May, and her email is below, and I'm certain that CCIH will send that information out. But we would be happy to have your participation, your knowledge, your learning, your questions, because this is really the time, and we know this in our world, where we need to have good leadership, strong systems and structures in place, and then really inspiring leaders to create more leaders. So thank you all so much. Thank you, Perry, and back to you.
Thank you, Janelle. And I definitely want to welcome people to join I think the more people that we have, the better product we developed as a team. So I encourage you, if you have interest in being part of it, reach out to May or to one of the other members, and we'll get you plugged in. Yeah. So now we have about 15 minutes or so for question and answer. So this can be for any of the specific presenters, from Kate on to Janelle. We have, while you think about your questions, I'm going to ask one or two questions, and then we'll also open it up for people to ask specific questions. I think I saw that Kate is still on. Kate, we had one question that was very much on my mind as you were presenting, having led a large USAID project, and knowing the pressures and deadlines, and it's not like, well, you can tell Congress that we were having our Sabbath, so we didn't meet our targets, or we didn't get our reports on time. How do teams really kind of prioritize that work-life balance within a team that has these very demanding deadlines and requirements? How have you seen that work?
I think we're not sure which Kate you're referring to.
Oh, Kate Rademacher. Yeah, it would apply to both, really. Yeah. Let's open it to all Kates on the call. Yeah.
Okay. Oh, can you hear me now?
Yes.
I didn't have the right to unmute myself. Great. So thanks for that. And I just want to speak directly to the question about USAID funders, because actually what I'm seeing is that there really is an exciting opportunity to do some co-creation with donors on this. I think it's a new opportunity, but one that we need to really seize. So I think because the World Health Organization classified burnout as an occupational phenomenon, and there is evidence on that, we can lean into that. In addition, there's just growing awareness of this issue in our news media, in our culture. I think one of the side benefits of the pandemic has been increased awareness and compassion around some of these issues, which of course have been challenges for a long time, but have become exacerbated. So for example, I was extremely grateful to receive an invitation to talk about burnout at USAID at the Global Health Bureau in April last month. And about 100 people showed up from USAID internally. And so first of all, what I'm hearing is that donors themselves at USAID and the Gates Foundation are experimenting with solutions to address burnout themselves internally, but also that there's increasing awareness about some of the ways that expectations, targets, timelines affect implementing partners. And then of course, also thinking about burnout at frontline healthcare workers and the communities we work with. So I do think that the time is now to have these conversations. And what I'm advocating internally at FHI 360 for what I work is that we need to lean into these conversations at multiple levels. We need to lean into them at the project level, and that we can even include some principles and practices related to burnout, for example, in gender strategies that are due often as deliverables for projects, included in M&E processes and pause and reflect sessions, perhaps in co-creation sessions that USAID is convening, and that we need to talk about this with our donors, again, because they are burnout too. And so this has to be part of the conversation we have. And I think if we start discussing it early and often, and then also with senior leadership, we had a nice introduction from one of our US senators. I don't think it's outside of the box. I mean, it is outside of the box, but I don't think it's outside of possibility to have really high-level discussions with decision makers about this issue for multiple reasons, because of a Sabbath ethic, but also because we know that if we want return on investment and if we want impact, having a sustainable workforce that is rested, that is sharp, is actually the key to impact. So thank you for that chance to expand a bit, but and hope I didn't go on too long, but thank you so much.
No, it's so important to the advocacy with the people who are kind of expecting the outcomes. If you can translate something healthy for your organization into a reportable outcome, it's especially for task-oriented people, maybe will actually do it and not just have it be a checkbox, but it also creates that understanding on their part that this is actually a part of having a well-functioning organization. Kate or any of the other presenters, do you have anything else you wanted to add to that question about how do you balance that?
I think the thing that was coming up for me, Kate, as you were speaking initially and now, is the ways that burnout, which is, you know, what we kind of have this official designation of now, but also vicarious trauma and a concept called spiritual struggle or spiritual distress. In the research that we've done, they're very interconnected. So we tend to be able to say, you know, again, we're talking more in an epidemiological level, not necessarily individual, but it's likely that if somebody is experiencing burnout, they're also experiencing spiritual struggle or distress. And we know that professional obligations can be a source of spiritual struggle. And as Christian organizations, it's really important that we think about our staff and how their own spiritual lives are. And that then is part of how we be mission forward, because being mission forward and having those pauses, those reflections, that space in the schedule to attend to our spiritual lives helps us bring the mission out. And so all of these pieces, right, it's a big puzzle, but it does really fit together beautifully. I think that's part of the spirit side of it, is some of the struggles fit together, the vicarious trauma, which has been so high in COVID, the spiritual struggle and the burnout, but also some of the solutions can address all of those things like in a beautiful package. And so I love that. Thank you.
I think that term vicarious trauma may be unfamiliar to some people, but I think it's so important for us to recognize that people in health-related ministries, especially in these under-resourced settings, it's a daily experience that you're face to face with death. You know, not only do you see death, but people are looking to these providers to help stave off death. So it's not just that they're seeing it, but they are actively being called into it, and it's a very real thing. We're seeing a lot of burnout related to vicarious trauma. Excellent. Anything else? Anyone else that want to add from our panel here on Sabbath rest and balancing work life before we move on to the next questions? One other question that we had for Dr. Alima during the and whoever, during the COVID epidemic, we talked about leadership within the hospitals and health ministries. Did you see any leadership from within the faith, really the faith leaders, the pastors and the priests and the bishops, whatever, who were providing some good information and good encouragement during the time of the epidemic?
Thank you so much. Yeah, I think over the time of the pandemic, the support from church, from the faith leaders, I think was very critical. And indeed, apart from the information, the medical information and guidance, SOPs to prevent transmission, it was very important that the faith leaders come in to give messages of hope. And I think that was an area that was strengthened at that time. So not only were we helping, supporting the clients with medical information and treatment, but also bringing in the faith leaders to talk to their congregation, one at the places of treatment, but also in their congregations to be able to pass out messages of hope and encouragement as families and members went through the difficult times. It was indeed critical. We did come out with an approach that we called faith and community initiatives. And in this, we combined both what would have as the mainstream of community health services, working together with faith leaders. We trained, I think, about 900 to 1,000 faith leaders to be able to give messages of hope, and then attached community liaison workers with them. And so they were not only preaching and the gospel, but also being able to give messages of hope, but also supporting in the processes of referral, identification of those who are unwell. So we did really engage the faith leaders, and this worked a lot. We saw lots of referrals, and at the time of the pandemic, I must say, there were areas like abuse in the families because of the stress and tension in the homes, gender and sexual-based violence coming up.
And so they were helping with identifying our clients and referring them, but also we were working with them to be able to support these families beyond the health care that the facilities can offer. And so that interaction, that collaboration did work really well, including identifying that did need our support. Thank you.
Excellent. I think lessons that we've learned, I think in particular with Ebola and now with COVID, is that people look to their faith leaders as a reliable source of information. And often, I mean, we saw, there's so much distrust in government and CDC and science, and so it's important in between these epidemics that we really encourage strong relationships between health ministries and faith leaders, so that trust is developed, so that we can get good information out through these channels, because they're very, very powerful channels. Any other comments about faith leadership?
Chair Perry, I think just to reinforce what both Kates were saying, it's a beautiful thing. It's not just, you used the helpful vocabulary of getting the message out through these faith leaders and believers of various kinds, but there's also them themselves. So part of what we're doing as health workers is integrating. So as we ourselves are connected with the Lord, resting, able to see that this is not just our work, but it's the Lord's work, and then helping them to have that perspective, that's integrating them, which is only going to forward the impact of not just the work we do, but who we are in doing the work that God has called us to do.
Yeah. I have a question here for Kyle. If you were advising other hospital organizations preparing for situations like COVID, what would your #1 piece of advice be to prepare organizations for epidemics?
Wow, that's a good question.
Easy question.
And we've done a lot of contingency planning, and it's tough. We don't have anything necessarily real and tangible in some ways. We've maybe never been through that experience before. I really do think it's imperative that we get together and prayerfully begin. I think leaving God out of the picture in our responses could lead to a disaster. What He's calling us to do in any type of situation. I think that's for me the primary thing. Be on our knees, praying, putting our heads together. One of the things I see happening in a pandemic when we're trying to plan and prepare is during the middle of it is there's a lot of tension, stress. I think the biggest thing is to try to have an environment where we're listening and not condemning. There's a lot of really good ideas out there, and some that may be right outside of the box, but really listening to everybody from communities participating in that, along with people maybe within our own staff who have experience, just allowing them to the table, because there's a lot that can be missed by the experts.
Sure. Excellent. There are a couple of questions about organizational capacity assessment. One is whether or not the OCA tool that you had mentioned covers anything related to integral mission, and integral mission, being basically that integration of faith, spiritual ministry, and with physical ministry. Is there some measure that you have, qualitative, quantitative, within this tool? Maybe Doug or Martin, you could address that.
Or Florence, I think Florence was also commenting about the faith engagement. I'll say very quickly, we within the OCA tool specifically, we didn't build in a faith component into it, but we built a separate tool and we thought that would be complicated to talk about in our time here. So we have an entirely different faith engagement or faith-basedness tool, if you will, which says what are you doing internally in your organization? What are you doing externally from your organization? And how does that reflect your idea of what you want to be as a faith-based organization? Frankly, we have a tremendous variety of organizations in CCIH, some that do very different things with a faith motivation than others. So what is it you're trying to do? And are you then doing it the way that you thought you would? So that's something we'll be talking more about later. But please, Martin, Florence, over to you.
Just to add on what Doug has said, the tool we have so far does not have that, but we've started asking questions in that direction. What makes us unique as faith-based organization? There must be something that's unique about us that will make us do things differently. In fact, there's a tool, I don't know if it's the same tool you are talking about, Doug. There's a tool that I shared with the 7 CHs that we are working with. It's about some profile and characteristics of faith-basedness. So we are already going towards that direction. Once we are able to identify those key integral parts, we shall work with the relevant people to include them in the tools. But that's very important because we may lose our identity, purpose, and values as faith-based organizations if we don't have that in our tools. Thank you very much.
That's the very one. We developed that with IMA, World Health, and World Council of Churches too.
Thank you.
And I see Dennis.
Is there a specific reason for not including that in the OCA tool because it's more of a secular tool, or could there be some component added to that, Dennis?
Well, let me just make a comment. I think we are referring to the same tool. Of course, the OCA CCIH had worked on, and the version of that was already rolled out. And so eventually, you remember the pyramid I showed and the commit piece in the middle, which is the values and the character of the institution. And so based on that, we have this tool that Martin and Doug alluded to. So we're trying to integrate that in a way. So I think we need to have more conversation. I think it's a fantastic, it'll be a great addition, and it will address the issue about integral mission, because spiritual and social dimensions, it doesn't have to be separate. You can measure them. And I think that's what will distinguish us from a regular OCA that everybody does, which I mentioned, is to assess the risk tolerance of an institution or the organization's ability to respond to a donor's fund management. But I think this is an interesting one and would be very fascinating. Over. Thank you.
Yeah. We had a question. Go ahead, Florence. Go ahead, Florence.
Just to add a little bit, I think that's very critical for identification of the identity of an institution, because we have gone through, and it's actually very, very, I would say, eye-opening, and then brings us back to know really what our values are. So I find that so very, very useful, because as an institution, we might have a different goal or separate goals and moving forward for identity. So that's a very helpful tool that I would also recommend this to be added into the OCA by CCIH.
Yeah. I think that we'd had experience with organizational OCA tools I've had for a long time, including the USAID ones developed by John Snow. And, I think there are different ways that these can be used. Often the donor has a motivation to say, hey, is this an organization we feel like we could support, or is it too high of a risk? So there's that donor piece about it. What is it that the donors are wanting to get from it? I think there's also an important thing from the organization itself as an institutional learning tool to say, okay, there's a checklist of things that now I recognize that other people say it's important to have this, and you can learn about what are the things that you put in place. And it, at least for me, starting with USAID, it really helped me know, okay, I guess I need to have a procurement policy or, all these things in place, or provide a useful checklist. You know, I think from the donor, if anyone could comment, you know, do you feel like the donors really see it more as a thing to protect them from risk, or something that is really genuinely because they want to see healthy institutions? Or is it both? I'll open that to anyone.
Well, I feel it is both, by the way, but there is a primary interest in being able to manage the money that they give you, right? I mean, there's an accountability that they have. Now moving towards this localization agenda and trying to strengthen local organizations. Clearly, we are now talking about 500,000 here and there, or it could be, but we are talking into millions and millions. So donor requires that you're able to manage that. So most of the stuff, I mean, I recently worked on an opportunity, and I was able to articulate these aspects that I mentioned. And I think it'll be very interesting to capture this. And USAID, of course, also is moving from capacity development 1, which includes all of the process and procedures, towards these elements that we were just talking about, you know, in a different way, not necessarily capturing faith, but the leadership, the accountability piece, et cetera, et cetera. But I think it's mutual interest, I would say, although your money needs to be managed. That's a primary interest.
Yes, yeah. Well, I think that's wrapping up our Q&A time. If you do have other questions, feel free to continue putting them in the chat box as we go, and or to email them specifically to the conference coordinators, and we'll do our best to make sure your questions get answered from the appropriate person. So it doesn't have to be the end. I know we could talk for a long time on that, but we wanted to move on now to our breakout groups, where we'll have a little bit more chance to be more interactive with you participants who have been sitting and listening. Now is the time for you to engage with one another and with us. So I'm going to hand over to Mona, who's going to take us through this process of breaking out into our rooms. So instead of sitting and having coffee together, we have a little bit of time to spend together. Mona?
Thanks so much, Perry, and to all of our speakers. Oh, you should see the notes I've written down, trying to keep up with everyone. I really, really appreciate it. So it's been personally a wonderful time of learning, and I hope that's true for everyone. Let's see, sorry. I'd like to tell us about how we can go to the breakout rooms, because at an in-person conference, we would typically be talking in the hallways and over meals and have time for networking. But we hope you stay with us for the next 40 minutes while we go to breakout rooms. There will be 6 rooms, and you'll be able to find them in a few minutes at the bottom of your screen. There will be a room in Spanish and a room in French, but there will also be 4 other rooms. So there will be a room on ethics. Are Christians held to a higher standard of ethics because of our faith? There will be a discussion on transformational leadership. How can we strengthen and inspire transformational leadership and good governance in our organizations? There will be a room on preventing burnout. How can we prevent burnout in leadership, particularly when the cause is good and the needs are great? And then there will also be a room called CCIH engagement, and that's where you can learn more about CCIH and how to get involved. So each room will have these discussion questions. We also encourage you to share, is there something you heard that was really surprising or encouraging? Was there anything that you thought was missing? Do you have any tools or resources that you would like to add about the topic of the conversation that you think would be useful to people? So after I pray, you should see a window pop up that allows you to choose to go to a breakout room, and I'll talk you through that in a minute. But let's pray together to close this time before we transition to breakout rooms. So I just want to remind ourselves, Father God, of our verse that we're focusing on for this conference from the book of Romans, chapter 12, verses 10 to 11, that says, be devoted to one another in love, honor one another above yourselves, never be lacking in zeal, but keep your spiritual fervor serving the Lord. And Father, we heard so much today that I think challenges me to think about, how do I keep my zeal and my spiritual fervor and be devoted to another and honor one another? From Father, how do we cultivate sustainability and rest in the Sabbath keeping, Father? The 5 E's of encouragement. I don't know, Father, how many other people were challenged or encouraged or felt called out about how to improve their leadership, and how to embrace Sabbath rest, and how to live out the call that you've given us to love one another, and serve one another, Father. So I pray that this time in the breakout rooms is an encouraging time to meet one another and discuss these important topics. I thank you for these speakers who so diligently prepared. I thank you for the ways in which the Holy Spirit spoke through them and guided them. And I just thank you for this community of gathering us together to share and learn from one another. I thank you for all of these things. I pray these things in Jesus' name. Amen.
Amen.
So thanks everyone for